Hello everyone, this is part 2 of NSAIDs. In the previous video, we talked about mechanism of action of NSAIDs and we also saw aspirin as the prototype drug. So in previous video, I told you that NSAIDs are broadly classified into non-selective COX inhibitor, preferential COX-2 inhibitors and selective COX-2 inhibitor. And I told that the mechanism of action of NSAIDs is mainly due to the inhibition of this inducible COX-2. So in previous video we discussed about aspirin among non-selective COX inhibitor. Let us move on to other drugs of the non-selective COX-2 inhibitor. This we have discussed and we saw that aspirin is the only irreversible COX inhibitor. And now we will talk about some characteristics of these other drugs. So first comes the propionic acid derivatives. In this propionic acid derivatives, we have brufen, naproxen, ketoprofen and flurbiprofen. So these propionic acid derivatives are better tolerated than aspirin and they also cause less gastric discomfort compared to aspirin, but still it is the most common side effect. Remember, they cause less gastric discomfort compared to aspirin. We saw before that aspirin, it is not used for long term and it is not used for inflammatory diseases, not used for its action as anti-inflammatory because it is not well tolerated. Okay, so these drugs can be given for long duration because they are having less gastric discomfort. They also cause less displacement reaction. We have seen in aspirin that how aspirin is protein bound, and if it is given with other drugs which are protein bound, then those drugs will be displaced and it can lead to toxicity of those drugs. Okay. On the other hand, propionic acid derivatives cause less displacement reaction, but still they are avoided with anticoagulants because like other NSAIDs, these also have antiplatelet action. They are going to decrease the aggregation of the platelets. So they are avoided with anticoagulants and they decrease the action of the diuretics as well, just like we saw in the prototype drug. Okay, so they decrease the action of diuretics and they are avoided in pregnancy. Now, because of being better tolerated, they can be given for long duration for diseases like rheumatoid arthritis, osteoarthritis, etc. So, what are the characteristics of some of these drugs? So, first comes ibuprofen. Ibuprofen, remember, it is a weaker anti-inflammatory. Okay. So, it is not used for rheumatoid arthritis, osteoarthritis generally. It is a weaker anti-inflammatory. But it is used for pain, used for inflammatory pain, post-surgical pain, toothache. And one very good advantage of ibuprofen is that it is approved for the use in pediatric patients and also in lactating mothers. Okay. Next comes naproxen. One very important advantage of naproxen is that it is long acting and can be given twice a day. Ibuprofen needs to be given 3 times a day. Okay, it has to be given TID. Naproxen can be given BD. So it is the preferred drug for rheumatoid arthritis, ankylosing spondylitis, acute gout, etc. So naproxen long acting and also most potent for anti-inflammatory action. Then comes ketoprofen. Ketoprofen can be used topically. Topical preparations are available. And then we have flurbiprofen, and flurbiprofen is used as ocular anti-inflammatory. Okay, so these are the characteristics of propionic acid derivatives. This part that ibuprofen abolishes antiplatelet action of low dose aspirin, this we had seen in the last video. So low dose aspirin shouldn't be combined with other NSAIDs. Moving on to other class of drugs, that is phenamate. In that we have mefenamic acid. No benefit over other classes as such. Then we have enolic acid derivatives. In this we have 2 drugs, piroxicam and tenoxicam. Piroxicam, like naproxen, it is long acting potent NSAID and it is used OD. Okay, it has a T-half of 2 days, so it can be used OD. Naproxen, we saw that it can be used BD. On the other hand, piroxicam can be used OD, but it has a higher toxicity profile. It can lead to GI bleed and serious skin reactions can occur. Azotemia, that is accumulation of nitrogenous waste products in the blood, can occur. So it is not the first choice, but it can be used. Okay. Then we have acetic acid derivatives, in which we have ketorolac. Ketorolac Again, it is a weak anti-inflammatory. Before we saw ibuprofen was weak anti-inflammatory. Now ketorolac also weak anti-inflammatory. But very important, ketorolac efficacy for pain is same as that of morphine. Okay, so it is very effective for pain, and that is why it is preferred for post-operative pain, musculoskeletal pain, pain due to bony metastasis, renal colic, and can be given intramuscular and IV as well. Okay, so for acute treatment of the pain, ketorolac can be given, but don't use for more than 5 days continuously because there is risk of GI and renal toxicity, right? Then next drug is indomethacin. Indomethacin also has higher toxicity. There is chances of renal toxicity, but indomethacin drug has been used for two conditions. One is patent ductus arteriosus. In the video on prostaglandins, we saw that one of the function of prostaglandin E2 is maintenance of patency of this ductus arteriosus in fetal stage. But after birth, there is closure of this ductus arteriosus. Now, in conditions in which even after birth, this patency of ductus arteriosus is present, we need to close it. And this indomethacin can be used for medical closure of this PDA because it will block the production of prostaglandin E2s. Then indomethacin has also been used in Barter's syndrome. Now Barter's syndrome is a condition in which, say, this is the nephron and this is the thick ascending limb of nephron. Here on the thick ascending limb we have the transporter sodium potassium 2 chloride. So in Barter's syndrome there is problem with this transporter. So it causes decrease in reabsorption of these ions. So there is more loss of these ions and this leads to hypokalemia. And this hypokalemia leads to production of prostaglandins in the kidney. Now, prostaglandin itself, again we have seen in the prostaglandins action that prostaglandins, it causes increase in the renal blood flow, causes increase in GFR, and it also decreases the tubular reabsorption. Okay, so once prostaglandins are produced and there is decreased tubular reabsorption, that means it is going to cause increased salt and water loss. So already we are seeing that because of the problem with this sodium potassium 2 chloride, there is salt and water loss, and now with prostaglandin production there is more salt and water loss. So this indomethacin blocks the production of prostaglandins within the kidney, right? So indomethacin used for two conditions, patent ductus arteriosus and Barter's syndrome. Next drug in acetic acid derivatives, we have nabumeton as well. Okay. Then moving on to other NSAIDs, that is preferential COX-2 inhibitors. This preferential COX-2 inhibitor term is used because these drugs inhibit COX-2 more than COX-1. Right. So this we have seen before that COX-1 is present in platelets and leads to the production of thromboxane A2, which promotes platelet aggregation. On the other hand, prostacyclin or PGI2 is produced by the vascular endothelial cells due to the action of COX-2 enzyme. Now, non-selective COX-2 inhibitors block both of these, thus they basically affect the platelet aggregation more in favor of inhibiting this platelet aggregation. This is affected more, so there is decreased platelet aggregation, so there is bleeding tendency. That is what we are telling, that there is increasing bleeding tendency is there with the non-selective COX-2 inhibitors. But with preferential COX-2 inhibitors and selective COX-2 inhibitors, this is not affected. Only COX-2 is affected. So, platelet aggregation, this pathway is intact. On the other hand, this pathway is inhibited. So, that means that is going to increase the platelet aggregation. So, this is going to increase the thrombotic risk. Okay, so please remember, very important, that preferential COX-2 inhibitors and selective COX-2 inhibitors, they will increase the thrombotic risk, while the non-selective COX-2 inhibitors, they are going to increase the bleeding tendency. Okay, so moving back to our preferential COX-2 inhibitors, what are the drugs we have? We have nimesulide, diclofenac sodium, then we have esclofenac, meloxicam and etodolac. 5 drugs are there. Nimesulide is a drug which is banned in many countries because of chances of fulminant hepatic failure. So it is banned in many countries. In India, it is not banned yet. but it can be used as anti-inflammatory in patients with aspirin-induced asthma. So this is a hypersensitivity reaction side effect which can occur with aspirin, where we cannot give other NSAIDs as well, because if aspirin has caused the hypersensitivity reaction, other drugs will also cause the same reaction, but nimesulide has not been found to cause such kind of reaction. Then next is diclofenac sodium. Diclofenac sodium is one of the most extensively used NSAID, and it is another drug which is preferred in rheumatoid arthritis, osteoarthritis, and ankylosing spondylitis. We have seen that naproxen is one drug because it is a long acting and a very potent anti-inflammatory. So second drug which is preferred is diclofenac sodium for this anti-inflammatory action. And diclofenac sodium has also been found to have increased synovial fluid concentration. But as other COX-2 inhibitors, there is increased thrombotic risk, so there is increased risk of heart attack and stroke. Then we have other three drugs, that is esclofenac, meloxicam, etodolac. Side effects and actions are similar to that of preferential COX-2 inhibitors. Sometimes esclofenac is preferred over diclofenac because it has a better tolerance. It has a less GI side effects compared to that of the diclofenac sodium. Moving on to the selective COX-2 inhibitors, which are also known as COX-CYPs. These include celecoxib, etoricoxib, parecoxib, and remember that because they are selective COX-2 inhibitors, there is much more increased thrombotic risk. However, gastric mucosal damage is lesser. Again, in the prostaglandins analogs video we have seen where we detailed about the actions of prostaglandins, that COX-1 enzyme is important in stomach for the production of mucus bicarbonate layer. So when that is blocked, there is increased gastric mucosal damage as occurs with non-selective COX inhibitors. With COX-2 inhibitors, there is decreased gastric mucosal damage, but there is increase in thrombotic risk. Also, salt and water retention is more because this COX-2 is also produced in the JG cells, and in kidney it is responsible for the production of the prostaglandin. So that is blocked and there is more salt and water retention and increase in blood pressure. So in selective COX-2 inhibitors, we have three drugs, celecoxib, etoricoxib and parecoxib. But remember, high thrombotic risk. In fact, some of the drugs have been withdrawn because of increased cardiovascular ischemic events. Okay. So this parecoxib in this, it has high risk of serious cutaneous reactions as well. And if it is used, then it has to be stopped if rash appears. By the way, when do we use these selective COX-2 inhibitors? Remember that since there is high thrombotic risk, the use of these drugs is only restricted to patients which have high risk of peptic ulcer disease, GI bleeds and perforation. So for them only these drugs can be used. Obviously, when to use? We have to use for the anti-inflammatory action for diseases like rheumatoid arthritis, ankylosing spondylitis, etc. Now moving on to the last drug in NSAIDs, that is paracetamol. Paracetamol is basically coming under the category of para-aminophenol derivative, in which we have two drugs, phenacetin and paracetamol. Phenacetin is banned because it was found to have high incidence of analgesic nephropathy. But paracetamol is a derivative of phenacetin itself and it is much safer. Paracetamol chemically it is acetaminophen. So this has analgesic activity, antipyretic activity, but it doesn't has any anti-inflammatory activity. Remember, okay, so it is only used as analgesic and antipyretic. Why it doesn't has anti-inflammatory action? Because it cannot inhibit the cyclooxygenase enzyme in presence of peroxides. Peroxides are produced at sites of inflammation, okay, where we want the anti-inflammatory action. But this peroxides, because they are produced, this COX cannot be inhibited by paracetamol, right? But it has many advantages, this paracetamol. First of all, gastric irritation is insignificant, no effect on platelet function, not many drug interactions. So it is a very commonly used drug. In fact, over-the-counter drug used as analgesic and antipyretic. Also, it can be used in children, pregnancy, lactation and in all age groups. Okay. So very commonly used drug. But remember, It can cause acute paracetamol poisoning if taken in higher doses. In fact, the recommended dose for a day is only about 4 grams. If it exceeds 10 grams, then it will lead to hepatotoxicity. So what happens is that paracetamol is excreted by combining with glucuronic acid in liver. But some amount of paracetamol also leads to production of a toxic metabolite, that is N-acetyl P-benzoquinone imine. N-acetyl benzoquinone imine. This N-acetyl benzoquinone imine combines with glutathione and is excreted. Now, suppose if this PCM binding with glucuronic acid is overwhelmed, that means if there is decreased hepatic glucuronide conjugating ability, that glucuronic acid doesn't combine with PCM, that means more of the PCM will be diverted to production of this toxic metabolite. So this happens in case of the small children and in adults in case of larger doses. Okay. So more of this toxic metabolite is produced. Now it combines with glutathione, but glutathione stores are also limited, so it will be depleted. That means there will be accumulation of this toxic metabolite. Now this toxic metabolite binds with proteins in liver cells causing centrilobular hepatic necrosis and to renal cells causing renal tubular necrosis. So there is hepatic failure and also renal failure with acute paracetamol poisoning. So that's why the dose should not increase 10 grams. It is contraindicated in premature infants because in premature infants there is decreased hepatic glucuronide conjugating ability, and also people who are taking alcohol regularly, in chronic alcoholics basically, there is induction of this enzyme cytochrome P450 enzyme, which leads to increased production of this toxic metabolite. So in them we see that even lesser dose can cause acute paracetamol poisoning. So you see the toxicity is generally seen with 10 grams, but the dose is limited to 4 grams. The maximum dose which can be given per day is limited to 4 grams. Because in some people, like in chronic alcoholics, production of this toxic metabolite is more. Okay, so even lesser dose can cause toxicity, right? So what is the treatment of this? One, remove the unabsorbed drug from stomach by inducing vomiting, gastric lavage, and activated charcoal also can be given, which prevents the absorption of the drug. Then antidote has to be given, that is N-acetylcysteine. N-acetylcysteine basically increases the glutathione stores and it also prevents the toxic metabolite N-acetyl benzoquinone imine from binding to proteins. Okay, so that is the antidote, and we need to provide some supportive measures as well. Okay, so that was about NSAIDs. In this video, we talked about characteristics of other NSAIDs apart from aspirin, that is non-selective COX inhibitors, then preferential COX-2 inhibitors, then selective COX-2 inhibitors. We also saw in detail about paracetamol, what is its uses and what is acute paracetamol poisoning and how it can be treated. And like all other pharmacology videos, the video notes of this video will be uploaded in the app for free download. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.